Hi everyone, welcome to ResearchMD.com. We have a great case today. We're going to be doing this series of interactive case discussion, and it will tremendously help you if you're presenting a case to the attending, or even your regular day-to-day knowledge, or like when you take the examination and all that. Okay, so if you have any comments or any questions, please put it under the comment section. We will try to answer that. Okay, let's start our case discussion today.
So there was a 62-year-old male who presented to emergency room.
62-year-old male
Presented to the emergency room with 2 syncopal episodes.
Okay, I'm going to stop right there. Okay, so we got a 62-year-old male with a syncope. My first question is like, what is wrong with your presentation? I'm the attending, you said, come up to me and said a patient presented with, like, what is wrong with that statement? What can you do? What is wrong with that? Should I get upset, you're the resident, or like presented the case to me and said like a 62-year-old came with a complaint of syncope. What is wrong with the statement? Somebody. This is a history of presenting illness, right?
Right.
Use like what's going on. If the patient is going to say like I got a syncopal episode, are you going to use it? No. What are they going to say? I lost consciousness or something.
Yes.
So don't, when you present the cases, the best way to say patient had an episode of loss of consciousness, that's the way to say it. Okay? Remember that. Okay. Now, but at least now we're talking syncope, I'm going to say. Every situation, what is the number one thing I'm going to ask? What is the number one thing I'm going to ask?
Emergency.
What is the emergency? You guys know that.
Yeah.
What's the emergency when somebody
Right.
with a syncope? What is the emergency? What could kill the patient? What are the emergencies? MI? Very good. So what is the term I'm looking for? Cardiogenic syncope. Okay. When a patient comes with a syncope, my job is to make sure this is not cardiogenic syncope, because that could kill a patient. If I miss it, the implications to the patient is much higher. Medico-legally, I'm also going to be liable for it. So my main thing is to rule out cardiogenic syncope. Okay? So when you talk about syncope, when the first thing come up, when I do when a patient with a loss of consciousness, okay, what is the first thing we have to do? Where is the best place we can get the history from? The patient or the family?
The family.
Okay, you always pick up the phone.
Yes.
Or call the family member or ask them to come in and tell me like what exactly, because 95% of your diagnosis come from the history taking, especially syncope. Otherwise, you're going to be doing like millions of tests with no use. Okay. So we talk about let's talk about syncope now. Some of the differential diagnosis right here. Okay. Before I go to my differential diagnosis, what is the mimic, or like what is closer to syncope presentation? Which disease? Seizure. Okay, my goal is to make sure it's not a seizure. Very good. So how do you make sure this patient didn't have a seizure? What are the to rule out seizure in this patient? That's the first thing I would do. What do I do?
Duration of the episode.
Very good. The duration episode, usually like syncope is like what? Less than what?
1 minute?
Less than 1 minute. If it is more than 1 to 5 minutes or 1 to 2 minutes, then you can kind of think about a seizure. What else? Duration very important. What else?
Prodromal symptoms.
Prodromal symptoms, right? What is that? Metallic taste in the mouth, like nausea, or sometimes some of those symptoms can also they knew something was kind of coming up, right? That's what this is like. I feel like something bad is going to happen, those kind of things. Okay, what else? What is the other word I'm looking for? Postictal confusion, right?
Okay.
Very, very important. What is postictal confusion, right? What happened to the syncope? Patient has a syncopal episode, they're back to normal, remember everything. What happened to the seizure? They got postictal confusion, right? And what else? What is the other thing, common thing? Micturition, defecation, right?
Yes.
Those kind of things you just gotta
Right.
remember, like all of those kind of things. Okay?
Right.
All of these things kind of make sure like it's not a seizure episode. Very, very important to rule, those kind of things. Now let's talk about the differential diagnosis of syncope. We can say neurally mediated. Okay, and then we can say cardiac, right? And then we can say what? Orthostatic, right? orthostatic, and then what else? The last one we can say like psychiatry, right?
Right.
Psychosis. But that's the last minute. Every time I said don't like bring anything in, even if you suspect everything, don't ever bring psychiatry into a medicine picture right there. That's not our job. Our job is to make sure, use your brain to figure it out, like what's wrong with the patient and all that. Okay, so we need to know when you talk about neurally mediated, that kind of vasovagal, that comes into, you got carotid sinus, I say like vasovagal, right? What is it? Carotid sinus reflex?
Yes.
Okay. So before we go into, let's look at some numbers, all right? What does that say? Like if we cannot express in numbers, that means you don't know the situation. Okay, so always you remember some numbers you see if you can express it, right? If somebody scored like this much and then it's like, wow, right? Then I say that comes into a picture. So if you cannot express the numbers, you don't know. That's the way I look at it. Always express in numbers whenever see that. We'll come back to it. So what happened? So we need to know what percent of the people have syncope in their. What percent of the people have syncopes in their lifetime? Give me some numbers.
5%.
Huh? 5%?
10.
So you got 5, we got 10, anything else? Come on, higher.
12%.
So almost like 35 to 40% of the people have at least one episode of syncopal episode in their life. So in their lifetime. So it's very common. Okay? So we do and all that too. And then, most of the time we talk about is a neurally mediated syncope. Remember that. Okay? Around 35 to 40% belongs to this category. Okay? Neurally mediated or carotid sinus reflex. Cardiac syncope, remember? What percent of the people have cardiogenic syncope when they come to the hospital? Or any studies, any numbers, express in numbers? So give me some numbers. I need to know the
60.
number. 60%, okay. What do you say?
30.
30%.
15%.
15%. The number is almost 20%. Okay, remember that number. So we have around 20% of the people can have cardiogenic syncope. That's a pretty good number if you look at it, right? So you need to take it very kind of seriously, syncope. Orthostatic. What are the causes of orthostatic? What could cause?
Medications.
Huh? Medications can cause it. What else? Volume depletion, right? And the other thing is anytime we have autonomic failure, right?
Yes.
Primary multisystem atrophy, the people have Parkinson's disease,
Right.
and those kind of things can cause autonomic dysfunction that can cause it. And psychiatry again, what is the people usually kind of fake, right? They love to fake syncope or seizure, right? So it's kind of it's the last minute, but we just have to think about it. Right? So when we need to let's go back to syncope. So tell me phrase it the proper way. What are they properly at the presentation? Say, so we know.
So the patient presented with loss of consciousness.
Very good. Now you're learning loss of consciousness. Now we need to know what else. What else do we need to know about the loss of consciousness?
Duration.
We need to know duration. How long was the presentation?
45 seconds.
45 seconds, right? So what does that tell us?
It's about syncope.
So it's
not a
syncope,
seizure.
it's not a seizure. That's the only thing I know.
Right.
Okay. What else? Do we need to know the position of the syncope?
Yes.
Right? Why is that? Why is it important do we know this position?
To differentiate amongst the different
Differentiate,
kinds
you
of-
can go over with the neurally mediated cardiac or orthostatic, those kind of thing, right?
Right.
Which position? Now we already said there's 20% cardiac syncope. So what questions I can ask for to rule out is not in the position? What position usually present with the cardiac syncope?
Squatting.
Huh?
Squatting.
It will come back to that. Okay, what else? Usually
Resting.
patient is lying down,
down.
right? Lying down, or sleep. There's syncope in the sleep. Those are the main kind of cardiogenic. Let's say other orthostatic or neurally mediated patient usually standing up, right? And then standing for a long time, this could have happened and all that. Okay, so the other thing, let's say somebody come to and say we are a tight collar. Why is it they have a syncope? What is that? Carotid sinus, kind of and all those kind of things, right? So common, I had a patient one time, he was shaving, he had a syncopal episode. What do you have to worry about? Carotid sinus also, right? The reflex and all those kind of bradycardia and all those kind of things. So position is kind of important, what position the patient have. What about the symptoms? Let's say if this patient, like let's say cardiac syncope, what kind of things, you already said like, an exertional component, right? I'm doing like another exercise, running, then I have a syncope. Then I have to think about a valvular disease like aortic stenosis and the cardiac syncope is higher, right? And then if you have like somebody said like I'm having palpitations also, right?
Yes.
We need to know like, that's kind of go with the symptoms of what? Cardiac syncope, those kind of things, palpitation, the exertional component, and patient is kind of lying down, syncope, patient is, syncopal episode at night, those kind of things. So we talked about it. What else we need? Anything else on this patient? On the syncopal episode, do we know?
That patient said that when his episodes were when he was brushing his teeth.
Okay, so
He
he was
felt uneasy.
brushing the teeth. That's also kind of say like, he was doing something and, could be like a carotid sinus kind of something that also like, those people even they turn the neck, right? They can
Yes.
have like, and all those kind of thing comes into play. What else?
That's it. Patient denies any loss of bowel or bladder control during the
Why is that
episode.
important? Again, seizure, right?
Seizure,
If you
yes,
say like you did
seizure.
not have any of that,
Right.
right? Okay.
Patient also denies any head injury or any
Okay,
tongue
and
bite.
then do we need when we talk about I think it's very important when you said about what he was doing, right? That is called what? Situational
Situation.
syncope. Can we call what are the other common situational syncope? One is
One is
cough
cough.
syncope, right? Micturition syncope, right? And this guy was like brushing the teeth. Can he be like a situational syncope? We can write it. Remember? Okay, like situational syncope, just remember that. Okay, so remember all those kind of
Yes.
points, very, very important. 95% of the things you can kind of come into. Think about micturition syncope. There's like, cough syncope. That's like the most kind of common things and all
Yes.
that. Okay, now we did the past medical. Let's go to past medical history. What is important in the past medical history? What is important? What do I need to ask? Before, I'm not going to ask you. Tell me, what do I need to ask the patient?
Any cardiac history?
Any cardiac history, okay. Any cardiac history.
Any previous
MI, what else? Only even arrhythmia, all fixing it. What else we need to ask?
previous episodes of syncope.
Yeah, okay, previous, that also kind of put a high risk, right?
Yes.
Previous syncope. If somebody have like 2 syncope per week, I think the risk of cardiogenic syncope is like extremely higher. Okay, what else we need to know? Previous
Medication.
syncope, cardiac history, what else we need to know?
Current medications?
Current medications, we'll come back to that. I think
Okay.
that is in the other thing, but mainly I think we just need to worry about tell me the past medical history of this patient.
Past medical history is not significant. He just has hypertension, but nothing related to any
Okay,
cardiac.
so that kind of also vasovagal kind of thing when you
Yes.
have hypertension, right? Because
Yes.
you have blood
Yes.
pressure medicine and those kind of thing and all those kind of thing, I should be worried about. Okay, and then allergies important?
Yes.
Do you have any allergies?
No.
No allergies? Okay, and then what else? Medication, what medicine the patient on?
The patient is taking losartan and ezetimibe.
Losartan?
Ezetimibe.
Okay, and then we talk about, past medical history also, we need to know the patient have Parkinson's disease, those kind of things can cause autonomic dysfunction, right? That's important too. And then, family history, what else we forgot in the family history, why is it important, family history?
If anyone in the family also had episodes of
Episode of what?
seizures or syncope.
No, what is that term I'm looking for? Sudden death.
Sudden
Okay, if somebody in the family history of sudden death, then you have to be very careful. So always look at the history but there is no sudden death in this patient, right?
Yes, no
Okay.
significant history.
All right, and then social history, what do we need to know? Why is it
Alcohol,
social history is important?
Chronic alcoholism.
Chronic alcoholism, that can cause orthostatic hypotension, those kind of things. Vasovagal thing is very kind of common and all that too. What else? Is he a smoker?
No, he's not a smoker.
I don't think it's not that much important also. And okay, what else? Social history we need to know. What else? Right?
Yes.
Okay, and then what is the psychiatric history? Do we need to know psych history? There is a component, right?
Right.
So it's good to know like what's kind of like, I'm not saying like, I mean, that's my last differential I usually
Right.
kind of think. Okay, don't ever think about, I usually discourage people to give me a diagnosis of like everything in the world I put upside down before I come with the psychiatric. So it's good to know the psychiatric history also. Okay, so it's also
Yes.
negative, right?
Yes.
So what are the things we have to like? So only thing, what do we need? What do we know so far? Based on this, what like, give me one diagnosis. Remember we said like 95% of the time we get our diagnosis without going to this $1 million investigation and all that. So based on this, whatever we presented, what's our diagnosis?
Maybe a neurogenic
Okay.
syncope.
Everybody agree with that?
Yes.
Okay, because this is like in a situational syncope could be the one, neurogenic or the neurally mediated, I would say.
Right.
That's my kind of thing. Because past medical history, didn't have any cardiac arrhythmia history, family history or no history of sudden death. None of this like, red flags hasn't shown up, right? And this episode was like less than 1 second, less than 1 minute and all that. So, what is the first thing we need? Vital signs. Tell me the vital signs.
Blood pressure is 121/75.
Okay.
Temperature is 36.1. That's normal. Pulse 65.
Uh-huh.
Respiratory rate is 18.
Uh-huh.
And SpO2 93%.
93%. Okay, am I happy with this vital signs? Or do we need to check anything else? What should I do next?
ECG in the vitals.
Yeah, I'm on the vital signs. Why did you jump into ECG or EKG? Am I happy with the vital signs? What else I should get on this patient? That's the question. Huh?
I think your
Come
heart
on.
rate, you considered the heart rate?
No, what else? What is the term we're looking for? What is this called?
Orthostatic.
Okay, always check
Right.
for
Right.
orthostatic. Don't forget to
Right.
do that. When somebody with syncope, make sure you're not happy with these results. Let me get the orthostatic, make sure the patient didn't have it. So what am I looking for? Systolic blood pressure less than 20, diastolic 10, heart rate greater than 20. Okay,
Yeah.
so those kind of things. You put the patient lying down, sit up, wait like 2 to 3 minutes, and then do measurement and ask somebody or the nurse to do it. A lot of times I just pick up the blood pressure cup and try to do that by myself, so I know what's going on. Okay, because and all that too. Now, what are the things? Examination, right? What are the most important thing? What am I looking for? I don't want you to do taking like an hour. What's some focused investigation we need to do on this patient? What are the things?
Neurological.
No, listen, neuro is what is the first thing? Let's look at the patient, outside examination, what am I looking for?
If he's oriented and
Okay, very good. He's oriented. Is he alert oriented
Yes.
times 4? That's very important, all that. Why is this skin examination is important in this patient?
To look for any bruises. Or
Yeah, soft tissue injuries, very common. When somebody with syncope, take all his clothes off, look it up. When you have seizure, what happens?
tongue bite, and then we have
Yeah, tongue bites, that we'll come back to that. But they have they just kind of go shaking in the
Yes.
a lot of soft tissue injuries very common. Somebody said somebody have 100 movement. I think if it is syncope, some movement is common. The best way to differentiate, some studies have shown that if you have movement less than 10, most likely it's a syncope. But if somebody have they notice 100 movement or something like that, think about seizure. So always kind of look it up, and just make sure they didn't. And then you open the mouth, right?
yes.
And then what is it you got a cut. Usually I think it's the lateral
side.
right? Lateral region. That's what's very important also. Okay,
Yes.
very important to rule out. And then we did the examination. What is cardiovascular system is important,
Yes.
Yes.
or do you, examination of the neck? Why is it important? The examination of the neck.
Carotid.
More like a carotid bruit,
Right.
right?
Yes.
This is a carotid stenosis. Kind of have this bruit. I think is kind of more important on the neck examination, right? That's very important. What else? Cardiovascular. Why am I looking for? The valvular is important.
Yes.
Aortic stenosis, exertional component, right? We need to know all those kind of things. Rate, rhythm, and all those kind of things is kind of important. Okay, neuro examination important. Those are the main thing I think I should focus on, right? Anything else on there? Differential diagnosis, we talked about it, right? How was the examination? Anything? Everything was
Patient
pretty
was
normal?
alert and oriented to time, place, and person. So
And the
he was-
neuro cardiac and we'll just put a big within normal limits right
Yes.
here. Is that right?
Yes.
Okay. Now, let's go to the, we did all this. We did have to do some investigations, right?
Yes.
Now, tell me like which one is like important in this patient rather than doing like so many other $1 million workup. What are the things that's important?
ECG.
Okay, now, is it a lab? Let's look at the lab first.
Labs mainly to rule out
Okay.
any others.
CBC is important to you?
No.
It's not? CBC is important to somebody with syncope? What happens when you have low hemoglobin? Right?
Yes.
Right.
Yes.
Okay, can low hemoglobin kind of make people like syncope? Right?
Yes.
They have like the body cannot keep up, then what is the body is going to do? You need a circulation to the brain.
Right.
Body trying to keep you flat, right?
Right.
Right.
Boom, you just come down. So remember, so you look at the patient and so we just kind of write it down. Tell me the lab values, at least kind of
Yes.
look at it. What are the WBC, just look at it right here and then we kind of think about, what is the hemoglobin in this
Hemoglobin
patient?
is 14.
14, that was normal,
WBC is 3.5.
okay,
Platelets 119.
119. So we got two values up here.
Yes.
100, it's kind of on the low side. What is that? Is it normal or low? Leukopenia, we can
Yeah.
say that, right? I don't think anything can say, but at least every lab value, the first thing I do, I put a circle on it. What is this? Is it low? A little bit low,
Yeah.
right? Why should I be worried when somebody in the hospital with the low platelet?
Bleeding.
In the bleeding and all that
Yeah.
too, because most of the people, especially with a cardiogenic syncope, you have to give, you have to give like a anticoagulation or PE, those kind of things, and also, okay? And one thing I forgot to tell you, there's a study recently done, like people come with the placenta with syncope, pulmonary embolism risk was extremely high also. Okay, so we can add another thing like maybe cardio in this in between, like we can say PE also. Okay, so
Yes.
don't forget it. Think about like a pulmonary embolism way to do. You can do like some of the risk assessment. So when you have like a board question, when you have somebody with a low platelet, what is the first thing you have to do? So lab called you and said platelet is like 100,000. Platelet is 90,000. What's the first thing you're supposed to do? Come on, somebody answer me that.
PT, I know.
Wrong.
Okay.
Okay. You're fired. What is the
Repeat the labs again.
Repeat it.
Okay.
What happens is like platelet have a tendency to clump together. The first thing always take it, like the board question, any test you take, the number one, pick that, repeat it because of the they clump together. Okay. And what else? What are those? Tell me the numbers.
Sodium 136.
136.
6.
Okay.
Potassium 3.5.
Okay.
Chloride 100.
Mm-hmm.
Create 1.2.
What was the bicarbonate?
Bicarbonate was
27.
27.
Okay. B on creatinine
17.
and the creatinine
1.28.
1.28. Okay. So potassium may be slightly low. Why is it important? Potassium is important, Why is it the potassium and magnesium also important? Somebody with syncope?
Cardiac condition.
Cardiac arrhythmia, right? If it is low, we just need to worry about magnesium also. I would definitely check this patient also like a magnesium level. Okay, what else we need to check?
Doctor, we didn't even check magnesium. It was 1.6.
1.6, okay.
Yes.
So we got a low magnesium, right?
Yes.
1.6 is low. Potassium is kind of a little bit low. So I just kind of like make sure, like, my goal is to make sure to prevent arrhythmia. What are the things we have to do? Keep magnesium above 2, potassium above 4. It's kind of standard kind of thing you just have to do because that can produce like a lot of arrhythmia kind of things and all that. Okay, any other labs in this patient we should do?
Cardiac markers.
Cardiac markers is important. We said like 20% of the people can have like, right? And then what is the markers? Troponin, right? What was the troponin? Was it negative?
Yes.
That's all we need
Yes.
now. Within normal
Negative.
limits
No,
times
within-
3?
yes.
Okay,
Yes.
with times 3 we say like within normal limit.
Yes.
So also roll for BNP also. I would check, studies have shown if the BNP is high, more likely to be cardiac also. So I would check a BNP also. Okay?
Okay.
Now, what is the next thing we have to do? We did the lab. Any other labs we missed on this patient? Anybody have any other thoughts on this? No? Nothing else, right? So what else? Investigate. What are the other, like, we have to get EKG. right?
Yes.
What is the EKG? You could be like a bradycardia or like tachyarrhythmia, or main thing you can say like bradyarrhythmia and tachyarrhythmia, right? We need to know like an AV block and all those kind of things. If you don't look at it, we also need to see is an MI going on, right?
Right.
So what is the EKG showed? Is it normal?
Yes, it was normal.
Okay. Right, okay, so what's the next step? So we have all this the labs doesn't kind of show us anything. We know a little bit of magnesium is low. We know potassium is a little bit low, but all the other, we know like a little bit of, it's not very significant kind of thing. We know like troponin is normal, BNP is normal. Let's come with the assessment and plan. What is the number one assessment plan we do? What is the diagnosis? What is the diagnosis?
Situational syncope.
Okay, syncope, right?
Yes.
Most likely situational, we can say that?
Yes.
You guys agree with that?
Yes.
Yes.
Okay, most likely a situational. Situational, he was brushing teeth, right?
Yes.
Yes.
Okay, and then when you have what is the first thing I said? You give your diagnosis first, right? Not like a symptom or anything. It's a diagnosis, syncope. We got a good diagnosis. The next thing is the risk stratification. Okay, there's something called what is the risk stratification for syncope? Anybody? San Francisco syncope rule. Okay, remember that. The mnemonic you can use is called what? Chess. Okay, C is what? I will just maybe whatever write it down. I think probably better. So we'll do San Francisco syncope score. Rule or score, I think. Okay? So we they use the mnemonic, right? Somebody need to tell me what are the mnemonic we can use in this. What is C?
Congestive heart failure.
Okay, history of CHF. Does patient have history of CHF?
No.
No.
No. And what is the H?
Hematocrit less than 30%.
Less than 30%. We have that's not an issue also over here. What is the other one? E?
Abnormal ECG.
EKG, right?
Yes.
Abnormal. Do we have an EKG, abnormal EKG here?
No.
No.
No. Okay. And what is the other one? S?
Shortness of breath.
Shortness of breath. Does this patient have shortness of breath?
No.
No.
Okay. And what is the other S?
Systolic blood pressure less than 90.
Systolic blood pressure less than 90, right? So you got a blood pressure less than 90. So what is this? None of this thing. Now I know what is the next thing? My risk of have a serious cardiac event is very low, right? And then I would put low risk, right? And I'll also make sure orthostatic is checked, which you guys did not do in this patient, but make sure. I'm assuming that's also a rule. What is my next step? What should I do? $1 million workup I can take, right? What are the $1 million workup people do? MRI of the brain, CT scan of the brain. How much does that cost? A lot of money. What do they do? Echocardiogram, right? How much does it cost? A lot of money. What is it? Carotid and carotid? Ultrasound, right? Those are the common. Some people are also EEG, right? So how much you add up millions and millions of. So value-based care is when you are a resident or when you present in the case, this is very important to follow the value-based principle. So what should I do? Admit the patient in the hospital, do $1 million test, or let the patient go home? Answer me.
Let the patient.
Let the patient go home. Go home. Okay? Outpatient follow-up if you want to. Okay? Any questions about it? I will not do further investigation on this patient.
Okay.
I will tell the emergency room doctor, hey, but I will document it. You cannot. The mistake you can make is what? You write syncope, patient low risk, go home. But am I going to write that? No. Being a good doctor you should say, I did a risk assessment, I express in numbers, and it's a low risk, patient can go home, right? If in any situation, if something worse than happen, or it becomes a medical legal case, your beautiful documentation supported, the case closed, right? If it goes to a lawyer and all that, oh my God, this guy knows what's he talking about. That's very important. Diagnosis, risk assessment, let this guy home. Thank you so much for watching.